I'm going to talk about ultrasonography of the pelvis, and it's can be a very rewarding exercise to do, particularly because we know radiography is so limited, and we can image the pelvis transcutaneously as well as rectally, and that way we can then maximize the structures that we can see. But we still do have to appreciate that we are still limited with what we can see. There is still a significant amount of soft tissues that we can't visualize, but by doing this, we can certainly get a good appreciation of what abnormalities we might expect. So from the percutaneous approach, we can visualize the dorsal sacroiliac ligaments, the bony prominences, so the tuber sacrali, tuber ishii, and tuber coxae, third trochanter, the ilial wing and shaft, hip joint, and obviously the muscles as well. So the main two probes are the curvilinear and the linear. And transrectally, we can then look at the ventral aspect of the pelvis, so particularly the internal pelvic bones, as well as looking dorsally, we can see the lumbosacral disc, intertransverse joints, and sacroiliac joints. So just a quick recap in terms of our sacroiliac ligaments. There are lots really that then support this large and sort of very expansive joint. So we've got the dorsal ligament, which is made up of the dorsal parts that we can see in red there. So that extends from the tuber sacrali through to the sacral spines. We've got the lateral part, which clinically isn't particularly interesting, and I've certainly never seen a case that where we've got an abnormality in that area. We have the thoracolumbar fascia. It obviously isn't part of that sacroiliac ligament, but it fuses with that dorsal part of the dorsal sacroiliac ligament. The interosseous ligament spans the ventral surface of the ilium and the dorsal aspect of the sacrum. Obviously we can't assess all of these ligaments, but in some places we can assess a proportion of them. So in terms of looking at that dorsal part of the dorsal sacroiliac ligament, we have essentially do this mostly with our linear probe, and we can then start from the tuber sacrali and work caudally towards the sacral spines. And that ligament then changes in size and in shape as we move backwards. So it can start with quite a comma shape and then progressively come on and attach onto the sacral spines. And we can then obviously visualize that in transverse as well as in longitudinal, where we would expect a nice longitudinal fiber pattern. So in transverse, what we would then expect to see is just coming onto the, this is our dorsal part of our dorsal sacroiliac ligament here. This is our tuber sacrali. This is our fusion of the thoracolumbar fascia coming from the medial aspect. And that size and shape of that dorsal sacroiliac ligament changes quite vastly between individuals. So in this individual, we can see that it's quite thin before coming more comma-shaped and inserting onto the sacral spine, just coming into view here. And in other horses, that ligament is much thicker. So there's a huge range of variation between individuals, and it's therefore very important, obviously, to scan left and right side in order to compare each individual to make sure that you don't overinterpret any abnormalities. It is quite prone to artifacts, unfortunately, just because of its shape and because, therefore, we are going to be off incidence to that ligament. So this is one of the most common artifacts that we'll see, so a sort of a rounded area of reduced echogenicity within that ligament here. And again, that's really just because we're coming off incidence and because of the curvature of the fibers within that ligament. And we can then obviously see quite, in some horses, quite a lot of asymmetry potentially when we're comparing our left and right. And it's important then to try and establish what's causing that asymmetry. So that could be bone related, so the tuber sacrali could be at different heights. That could be ligament related, or it could be muscularly, because of a muscular change, a difference in the depth of the musculature because of atrophy. So again, it's important to try and establish what's causing that asymmetry. And also, it's very easy to put more pressure on the probe on one side of your tuba sacrale and create a difference in height. So you have to be quite strict with yourself in making sure that your pressure of your probe is very even between your left and your right side, so you don't create an asymmetry that wasn't there. I think that we can see quite a lot of ultrasonographical changes with these ligaments that aren't necessarily the primary cause of pain. I think they can adapt to chronic changes where lameness is caused elsewhere. And I think it's then very difficult to sometimes establish whether an ultrasonographical abnormality that you see is the primary cause of pain or not. So it's very important to make sure you obviously do a thorough clinical examination and try and then establish whether that is your focal cause of pain or not. So in my experience, it's not something that is very common. I've just got a couple of examples where I have seen a problem. So this was a 7-year-old thoroughbred horse that presented, had a history of a fall, and there was a query over a pelvic injury. So we can see this horse did have a bone scan, and we can see that we've got a focal area of increased uptake of the radionucleotide over this left tuba sacrale, and that we can see that we've then got matching changes on our ultrasonography, so irregularity of the bone, we've got enlargement of the ligament, reduction in echogenicity adjacent to the bone, and we can then obviously pick up this change as well as in our longitudinal view as well. So changes in the bone as well as a reduction and change in that longitudinal fibre pattern. So yeah, it's important not to just necessarily rely on your ultrasonographical findings. Any abnormalities that you see must relate to your clinical findings, and if you've got the advantage of bone scan as well, then that can be very helpful. This was a horse that presented as a little sort of cobby cross pony that presented with very focal pain over the left tuba sacrale. And we can see here that we've then got a obvious core lesion within this dorsal part of the dorsal sacroiliac ligament, and we can then establish that on our longitudinal view as well. So we've got a reduction in our longitudinal fibre pattern that we can pick up here as well. As I said, the lateral part of the dorsal sacroiliac ligament we can image with our curvilinear probe. It's not really, I've never seen a clinical condition of this part of the ligament at all. It's not something that's written up about, so it's a very rare cause of problems. But in general, yeah, the dorsal sacroiliac ligaments, I think they're useful to be able to scan. I think the clinical relevance of abnormalities in those areas is probably not particularly high, but it's important to establish that and to do that as part of your clinical exam, particularly for poor performance horses. So going on to the sort of ilium really, which is sort of particularly from a racehorse point of view, this is obviously one of the more interesting areas to scan. I think it's really important when you are scanning to try and have a mental image of the skeleton underneath the horse that you're scanning, so that then you can sort of picture exactly where you're scanning, because it is a bit of anatomy that is quite difficult to get your head around, particularly when you're first starting off. And essentially, as been well written up, we want to make sure that we scan the entire width of that ilial wing. It is a very broad plate of bone, and we do that by making sure we scan in at least 3 directions, in longitudinal and transverse, down from your tuba sacrale towards that tuba coxae and onto the ilial shaft. So what we want to see is then an even bone. We want to see that bone being nice and even, no irregularities, and we want to see the overlying muscular tissue as well being nice and even, nice and regular, no areas of hematoma or increased echogenicity. We have to be careful that in some horses, or in the majority of horses, to be honest with you, we can get artifacts within the ilial wing caused by these either muscle fascial planes, which then cause a defect an artifact within the underlying ilial wing. So we want to be careful that we don't then misinterpret those with fractures. As I said, most of the time they're caused by these fascia planes within the muscle, or alternatively they can be caused by blood vessels as well. They're generally very bilaterally symmetrical, so if you've got one on one side, you're going to have one on the other side as well. And not necessarily in exactly the same place, but you will generally have them on the left and on the right if you're not sure. It's really important to make sure you scan the entire width of that ilial wing, right from the cranial to the caudal aspect. A lot of ilial stress fractures, or the vast majority of ilial stress fractures in thoroughbreds, will start from the caudal margin of that ilial wing and won't necessarily go all the way cranially. So if you just scan the ilial aspect of the cranial aspect of the ilial wing, potentially you could miss something. We'll then, right at this caudal aspect here, we'll visualize the caudal aspect of the sacroiliac joint. So this is our caudal aspect of our sacroiliac joint when we've got our probe positioned right at the very junction between the caudal ilial wing and the sacrum. So what we have is the ilial wing here. We've got the transverse process of the sacrum going on to our spinous process here, and then we've got our sacroiliac ligament, sacroiliac joint in this region here. Okay, so it's not particularly a useful method in terms of establishing pathology in that area ultrasonographically, but it's important to know where it is, particularly in relation to potential stress fractures for racehorses. And if you are considering medicating the sacroiliac region from the caudal aspect, then obviously this is the area that you need to visualize in order to guide your needle most accurately to that area. We can see from this image here, number 5 is basically our sciatic nerve and our rectum. So we can see how close that is to the caudal aspect of our sacroiliac joint. So I personally, on that basis, don't medicate or inject the caudal aspect of the sacroiliac joint because I think you are too close to those very important structures, but some people obviously do. So ilial stress fractures, they are unique really to the thoroughbred or to the racehorses, and they can present in a huge variety of ways. It might be a sudden onset lameness, it might be a very slow, insidious onset, reduced performance, or it can even mimic something like tying up as well. So the other thing to realise is that the lameness or the pathology can be quite advanced compared to the onset of lameness because it's obviously a stress reaction, so things are then more advanced from a skeletal point of view than what we are necessarily going to see clinically. So as I alluded to earlier, ilial stress fractures, they generally start on the caudal margin. So this is one horse here, so we can see that we've got an obvious defect in the caudal aspect of that ilial wing. If we move cranially, it's completely normal. And again, this horse, we can see that it's sort of more advanced, more chronic looking caudally than in the cranial margin. And it's important, ultrasonography, as we know, is important for monitoring fracture healing as well. So we can then see in the acute stage, we've got more acute looking fragmentation and displacement here, and as we go chronically we get that callus formation and the rounding of the bone margins. And again, another example, again we can just get a more chronic appearance of the fracture as that callus is forming. And in the sort of long term, we can potentially just be left with a change in shape of the ilial wing. So this is the normal shape on the right side, and we can see that we've got more of a sort of acute angle that we've got left on the left side here. So just a few cases really just to sort of demonstrate of the variety of stress fractures that we might be presented with, both the variety from a clinical point of view as well as from the imaging point of view. So this was a 3-year-old thoroughbred racehorse. The complaints from the jockey was bunny hopping, it would just jump around, it wasn't cantering properly, no significant abnormalities or lameness detected on clinical examination. Continued an exercise. It was only worked on the flat and the canter then slowly improved. But after 5 days, it was then noticeably lame on that left hind. So from a bone scan point of view, what we can see is we've got an increased uptake of the radionucleotide on the caudal aspect of that left ilial wing. It is more caudal. It's not extending the whole way across to the cranial margin of that ilial wing, but is obviously extending, is taking up a reasonable amount of that ilial wing. And from an ultrasonographical point of view, again, we can see, as I said before, we can see changes in the caudal aspect of that ilial wing, but not on the cranial aspect. Okay, so it's just important to make sure we follow those through from caudal to the cranial aspect, and we can then look at that callus development as well. So we've got sort of more of a callus formation here, which is this ultrasound is just slightly more caudal compared to this one. This horse is again a 3-year-old racehorse, presented more with like a horse that was tying up essentially. So it was a bit choppy, not an overt lameness, reduced the exercise, the horse improved. But again, when the exercise was increased again, it became choppy and stilted. So that was thought to be a tying up issue initially, but AST and CK were normal. And on ultrasound, again, we've got evidence of an increased uptake of the radionucleotide. Again, that is incomplete in nature. And again, what we can see is a more chronic appearance ultrasonographically compared to case 1. So this has obviously been more long-standing and been going on a little bit longer compared to case 1. So again, that's important to know because that might affect your management going forward and how you then progress, how quickly you can progress this horse through to exercise and stepping him up again. So the bone scan, the bone scan in this case indicates that although ultrasonographically this appears more chronic, it is still clinically relevant because it is still hot. Okay, so it is important sometimes to use those two imaging modalities together. This is a 2-year-old, stilted action behind, more obvious pelvic guarding, but otherwise nothing obvious. And again, what we can see here is we've got an increased uptake of the radionucleotide, and that's extending down the ilial wing towards the tuber cocci. And again, what we can see is that this is much more obvious on the caudal margin, and the fracture is more obvious on the caudal, much worse on the caudal margin compared to the cranial margin. So again, that fracture configuration can change. And again, a 3-year-old presented this time with a moderate lameness, so it was 4 out of 5. Otherwise, no previous history, sound within 36 hours. So again, this is more of a sort of typical stress fracture presentation. And this horse basically has a very different configuration to the presentation, to the scintigraphical findings. So we've got a long area of increased uptake of the radionucleotide on this ilial wing and extending on towards that ilial shaft. So that's obviously a very important area then to be able to assess scintigraphically as well as ultrasonographically. This horse, ultrasonographically, the fracture appeared to stop at that junction between the ilial wing and the ilial shaft. And that was quite important for this horse because it was had a big race coming up, and it meant that we were reasonably confident ultrasonographically with where that fracture stopped, which meant that we could try and push that horse to get that horse to the next race and get that horse back into training. But it did undergo very stringent, regular remonitoring ultrasonographically to make sure that we weren't missing something and that fracture wasn't progressing. And case 5, this was a 4-year-old. It raced, very lame afterwards, suspected pelvic fracture, and then this didn't need bone scan. We can then get much more obvious fracture configuration, obvious displacement, and this was complete across that whole entire ilial wing. And then case 6, this was a 3-year-old, severe and acute onset lameness. And we can see here, although the lameness is severe and acute, we've got just a subtle increase in the uptake of the radionucleotide. So we've just got a very subtle uptake here. Caudal aspect of the ilial wing. Again, it's sort of extending towards that ilial shaft. Okay, but scintigraphically, it's not as exciting as the others that we've seen. But from an ultrasonographical point of view, this fracture actually extended to that ilial wing, ilial shaft junction. So this is coming on to our ilial shaft here. We can see we've got obvious displacement here at the junction of the ilial shaft. So this means this horse needs to be managed completely differently. There's a significant risk that this could become catastrophic, and the prognosis is obviously reduced for this horse compared to a typical incomplete ilial wing stress fracture. So going on to our ilial shaft, we then complete our ultrasonographical examination of the ilial wing, and we then head down the ilial shaft, again, both in transverse and in longitudinal. And that will take us on to the hip joint. So the ilial shaft, as you would imagine, should be, again, a nice, smooth, rounded, bony contour. Shouldn't be irregular at all, and that will then take us straight down onto our hip joint here. This was a case that had a complete fracture, and by the time I saw it, it was a sort of healed fracture. But basically, it had a complete fracture at the back of this, the caudal aspect of the ilial wing, going on to the ilial shaft. So the fracture was basically right across this area here. It was complete. It was displaced, which we can see obviously from the ultrasonographical findings. And this horse was obviously very lame at the start, and although it improved, it remained very lame. And the other interesting thing that you could see from the ultrasound of this horse was that the hip joint appeared to be closer to the ilial wing than on the contralateral side. And this is what happens with these cases. So this is obviously a post-mortem specimen. So tuber sacrali, tuber coxae here. This is the hip joint here. So this is basically a more significant injury compared to the ultrasound ones that I found you, but essentially this has then healed, and you can see that that has concertinaed that whole pelvic area together. So again, that's an interesting thing that we can sometimes see. We might see this compared to our last case on the ilial wing. We can see more obvious involvement of our ilial shaft, and we can then pick that up ultrasonographically. So as I said, these cases are more significant. They do require cross-tying, and they will be much lamer, undergo much more severe muscle atrophy compared to our routine, our sort of more normal, typical ilial wing fractures. This is just, again, another example of how variable the stress-related injuries can be. So again, we can just see a mild uptake of the radionucleotide here at the very caudal margin of that ilial wing, extending onto that ilial shaft. And again, we can then pick that up ultrasonographically as well. So this is our ilial shaft. So it is very important to join those two imaging modalities together to make sure that your ultrasound can back up your bone scan, and your bone scan can back up your ultrasound to determine the significance of your ultrasonographical findings, and also make sure so we don't miss out on these ilial shaft fractures, which, as I said, can be catastrophic. So these ilial shaft fractures, they generally present or in the chronic state with a lot more muscle atrophy compared to the ilial wing fractures. So this was one, the horse that we've just seen with that fracture extended down the ilial shaft. This is plus 12 days and then at 10 weeks. So we can see that we get a significant amount of muscle atrophy on these horses compared to the ilial wing stress fractures. Moving on to the hip joint. We can then visualize this, as I said, in longitudinal as well as in transverse. So in longitudinal, what we can then see is this is our greater trochanter up here. Okay, so this is our trochanter here, coming down onto our femoral neck, coming down our femoral neck here. This is femoral head here, acetabulum, acetabulum here, and then that's our joint capsule here. So we can obviously, we can see a good proportion, obviously, extending from the cranial to the caudal margin of that joint. It's obviously limited, though, because we're only ever seeing that very abaxial aspect of that joint. We can't visualize what's going on inside at all, but we've obviously got this joint capsule here. So any joint effusion, we're going to then see bulging of that capsule, which is pathological. Okay, so that is gives us some indication, although we can't visualize exactly what's necessarily going on inside the joint. And in transverse, by just changing the orientation of the probe a little bit, we can then either visualize the acetabulum, or by then looking down a little bit more, we can then visualize that femoral head as well. So this is acetabulum here, and then femoral head here, and then here. So the femoral head is a little bit more rounded than the acetabulum. So this is normal, so this is just moving the probe. So this is femoral head, that's acetabulum, ilial shaft, moving the probe again, femoral head, acetabulum, ilial shaft. And again in longitudinal, so again, this is our joint capsule here, femoral head here, acetabulum here, and then that's our trochanter way up here. So as with any joint, you want to see nice, smooth, bony surfaces, no irregularity. It is important for adult horses to be weight-bearing when you assess them. It's quite easy sometimes for you to be concentrating so hard on scanning that the horse then suddenly rests their leg and you don't quite notice it. And that can then affect what you see ultrasonographically. So that'll then move your acetabulum in your relative position of your femoral head. So it's important then, obviously, just to keep an eye out for that. And then in the chronic case, this is a chronic case of a chronic acetabular fracture. We can see marked irregularity of the bone. So this is acetabulum here. This is femoral head. We've got marked changes in that femoral head as well. We've still got a lot of soft tissue changes going on, so a significant amount of hematoma formation on the outside of that joint as well. And then just another example of how severely abnormal, significant disruption of that normal architecture that we can see. So we've got the close proximity, basically, of the greater trochanter to the hip joint. So we've sort of got, again, a concertinaing effect of those two bone surfaces. So they're not normally, they're not positioned as you would normally expect them. And again, we see a significant amount of soft tissue change and hemorrhage into that periarticular area around the hip, as well as fragmentation of that hip joint as well. This was a little foal that presented with an acute left hind limb lameness. We can see, so we've got left here and then right here. So if we just look at the, this has got significant hip effusion. So this is our joint capsule here. And then we've got our joint capsule here, so that we can see that that is bulging away from the normal architecture. And again, we can picture that down here as well. So we've got, again, although we can't necessarily see any obvious fragmentation of the bone surfaces itself, we know that we've got significant effusion of that hip joint and indicating pathology in that area. This was a little yearling that presented very acute lameness. When you cracked on its pelvis, the whole bone's just cracked. So it was obviously something grossly abnormal. From an ultrasound point of view, we've got our ilial shaft coming here, but the acetabulum is positioned up here. And the femoral head is also sort of going off more at an angle. It's curving down here more. It should be positioned more in that orientation here. So we've got a significant fracture of that hip area. And on post-mortem, this yearling, it had jumped over a fence essentially and had basically sheared off the femoral head. It's completely fractured through that acetabulum, and it's also got a fracture of that ischium here. So significant pathology, which we can at least try and get some sort of handle on ultrasonographically, even if we don't necessarily see the huge significance or see as much severity as we would expect to. This was a osteoarthritis of the hip joint, so mild to moderate changes. Again, we can see a regularity of that acetabulum here. So we've lost that smooth, nice contour. So that's our acetabulum, and then our femoral head is positioned here, so that remains nice and smooth, but we've got mild to moderate changes of that acetabulum. You know, in big horses, the hip joint is difficult to visualize. So in your big warm bloods, etc., it's very hard to get good diagnostic images of the pelvis, particularly the hip area. In thoroughbreds, etc., it is obviously a lot easier, but I do appreciate it is quite difficult in these big horses. And these horses often present with quite a marked lameness, quite a significant reduction in that cranial phase, and they don't respond well to conservative management or to rest. They tend to remain, unfortunately, very lame. So just moving on to the sort of bony prominences, tubericium, tubercoxy, third trochanter. I'm sure you've all seen cases of these. So your palpation, you've obviously got a reasonable handle of these structures from a clinical palpation point of view, and you'll have a good appreciation of what you might expect to see ultrasonographically before you actually start using the ultrasound and putting the probe on the horse. So tubericium is obviously the attachment of our semitendinosus, semimembranosus, and our biceps femoris. And what we'll then lose is we've got a normal, nice, bony contour, which will become irregular ultrasonographically. So again, we've got normal on the left, abnormal on the right, and we can then get a variety of presentations of these. These can potentially be displaced or non-displaced. They do seem to take quite a long time to improve with respect to lameness, so it can be a good 4 to 6 weeks before these horses will respond to conservative management and that lameness will start improving, but they generally have a good prognosis. And we might be able to get whether it's a displaced or non-displaced fracture from bone scan, so we can see an obvious uptake here on the right tubericium, so that's a non-displaced fracture, and then we've got a displaced fracture on this horse here. So we can see that, we can potentially sort of predict what we're going to see ultrasonographically from our bone scan results as well. Tubercoxy, again, I'm sure we've all seen cases. It's not necessarily a clinical challenge to diagnose these, but the ultrasound certainly helps to sort of allow us to imagine or to know the fracture configuration that we would expect, and also make sure that we haven't got any extension down that ilial shaft as well. We don't commonly have that, but again, it's just something to check. And we can then obviously see a significant change in the shape and orientation of what we will see ultrasonographically. So we've got normal here on the left, and then we've got an obvious displaced fracture here at the bottom. Clinically, they can be quite variable, so we might only have a little mark on the horse, you know, if they've just clipped through a door as they've been going too close, or alternatively, we might have a much more obvious displaced and changing contour, and plus or minus a more significant wound associated with these. They can be quite useful to image radiographically as well. Sometimes it's easier to appreciate radiographically what we've got going on, and we do that from the contralateral side. And what we can see is this is the normal one on the right side, and then we can see a nice fracture configuration here on the left. And obviously bone scan as well can be our, again, a good way of looking at these. So we've got an obvious increase in uptake of our radionuclide by fractured tubercoxy. From a post-mortem point of view, we often will remain with a change in shape clinically for the horse. So this is obviously a healed tubercoxy fracture. So we can obviously see that this tubercoxy is healed, is going to be placed more ventrally than the normal side. But again, they do well clinically, and they don't seem to have a significant long-term poor prognosis following these. Third trochanters, this is again much more of a sort of a racehorse injury, to be honest with you. So we've got our bony prominence here is our third trochanter, and this is the attachment for our superficial gluteal. And we can then use either the curvilinear or the linear probe for visualizing these ultrasonographically. And again, both in longitudinal and in transverse. And the most common pathology is either a stress fracture or potentially trauma if the horse has fallen down. And what we are looking for is, we've got the third trochanter up here. This is our femur here, superficial gluteal attaching onto our third trochanter. And what we'll see from a fracture point of view is obvious disruption of that orientation. So we might lose the relative position of the third trochanter to the femur. We might obviously have displacement and fragmentation of this third trochanter like we've got in these two images here. And again, we can then assess whether this is displaced or non-displaced. So a non-displaced fracture, we're going to have our relative distance between the third trochanter and the femur remains normal, remains a normal distance compared to the contralateral side. And in a displaced fracture, we're going to have a shorter distance between this third trochanter and that femur. There can be quite a variable amount of bone scan uptake with these, so we can obviously see a significant uptake here by this third trochanter here on the left. Compared to, say, this one where we've got a much more subtle uptake. But again, this can help you potentially determine the chronicity of the fracture. So a little bit like your ilial wing stress fractures, it can help you determine the significance of this compared to your ultrasonographical findings. So here we've got superficial gluteal. We've got obvious disruption of this third trochanter, obvious fragmentation. And these horses, as I said, they require, we tend to rest them until they are sound, by which time you can start them off on a walking exercise program. And these horses do well, and they can respond, and you can get them back to work and training pretty quickly. Just going on to per rectum. It is useful, and can be difficult to get comfortable with initially, and it does require practice and patience when you first start off. And particularly when you're going to scan an abnormal horse, it's much more difficult than scanning a normal horse. So it is, if you can get to grips with scanning normal horses, it makes it much easier for you. So as I said before, we can look at the internal pelvic bones as well as that lumbosacral region. And we want to do this particularly if we've got a sudden onset lameness where there's been an associated fall or trauma and we haven't got anything else clinically on the horse. It's good to perform, I think, ultrasound even if your rectal palpation is normal, because again, your ultrasound is going to pick up things that you're not going to be able to palpate as easily. And if you are still suspecting a pelvic abnormality, then again, a bit like tendon scanning, it's important to repeat your scanning, 10 to 14 days following that injury, and look for further changes. So these areas highlight the sort of areas that are most frequently injured. So we've got the pubis, ischium coming on towards that inside aspect of that ilial shaft. And obviously what we're going to see is changes in our soft tissue. So we can see that we've got a significant amount of hematoma formation and soft tissue swelling on the injured side compared to the abnormal side, as well as a change in the actual bony irregularity as well. So this was a little pony that presented with an acute lameness and transcutaneous ultrasonography of the hip. We can see that we've got some hip effusion here. So that's our joint capsule up here. And rectal ultrasonography, we can see that we've got a marked fracture here, which is basically extending into this from this pubis area up in towards this axial aspect of that acetabulum, with significant soft tissue swelling as well. Looking at the dorsal aspect of the pelvis, the main things that we want to look at is our lumbosacral junction, our intertransverse joints, sacroiliac region, and then the nerve root outlets. And I think there's a huge amount that we don't appreciate or necessarily know about this area. we've got a lot of nerves in that area, and there's a lot of overlap where these nerves exit. So, really from L4 right the way to, S1, S2 are your main nerves that supply your hind limb musculature, and so any injury to those areas can then have a significant impact in terms of hind limb lameness, hind limb movement, etc. So a lumbosacral joint, we want to position the probe in the dorsal midline, looking up towards the sky, and what we'll want to see is this is our lumbosacral junction here. So we've got a nice triangular section here, so this is our disc. We've got a nice smooth bony surface of our back of our cranial aspect of our sacrum, and then the caudal aspect of L6. We often see these little gaps here which can represent the growth plates, particularly which are more prominent in the young horses. And we can then also move cranially in order to visualize our discs further cranially as well. Sometimes we get loss of our lumbosacral junction, so sacralization, so that can occur in in the literature anywhere between 10 and 30% of horses. So that's a completely normal finding, but what we will then see is often consequential enlargement of L5, L6 disc. So normally this disc is relatively small compared to the lumbosacral disc, but when we do have sacralization, L5 and L6 will be enlarged, and that's really because that's where the movement now is coming from compared to that lumbosacral junction area. So abnormalities that we might see, so this is our normal, so as I said, nice smooth bony surfaces, nice regular echogenicity. Any abnormalities potentially is going to be bulging of that lumbosacral disc, so that's one of the more sort of problems that's recognised as a definite pathology, is bulging of that disc. But we might also see significant changes with respect to the bony surface and the echogenicity of the disc as well. Intertransverse joint, we just move slightly left or slightly right of our lumbosacral disc. So we have our, this is our sciatic nerve root outlet here, and then this black gap here is our intertransverse joint. So again, as with any joint, we want nice smooth bony surfaces, nice regular surfaces. The sciatic nerve root outlet, so this one at this junction here, should have a nice linear pattern to it when you're in the right orientation, and the bony sort of bowl that it sits in again should be nice and smooth. And significant abnormalities, we can see we've got significant irregularity of the intertransverse joint, so that's our intertransverse joint here, so we can see that we've got significant bony irregularity, associated soft tissue swelling around that joint as well. Sacroiliac joint, we want to move slightly caudally and slightly abaxially, and we can only visualize the very axial aspect of this joint. We can't visualize this part, so there is a significant proportion of this joint that we cannot visualize rectally, and that is again is important to realize. So what we want to see is obviously the sacrum here, ilium here. This triangular structure is our ventral sacroiliac ligament that is sitting on the underside of that sacroiliac joint. And that joint will sort of change depending on how you orientate your probe. It can have a slightly different appearance, and you want to be able to then sweep as far abaxial as you possibly can in order to sort of visualize the entirety of that joint as much as you can. So this is our joint space down here, and then that's our sacroiliac, ventral sacroiliac ligament here sitting between those two bones. But as I said, it is important, we can only visualize, as I said, the very axial aspect of the joint, and we can only visualize the very ventral aspect of the joint. There could be a huge amount of pathology that's going on in there that we don't have any access to at all. Okay, so again, it's a limited procedure, but can be very useful. This is a horse that had significant disruption of that sacroiliac joint, significant bony irregularity, sort of lost almost the normal architecture completely to that area. So again, this was the normal sort of sacroiliac joint here, and here we've got sort of a lot of new bone formation and irregularity here. So these are rare cases. We don't often see pathology that's advanced as these, and it's when it's as advanced as this and it matches your clinical signs, it's much easier to take to call it as a significant finding. Milder changes are much harder to interpret their significance. So as with any joint, we can have a lot of changes there that aren't necessarily clinically significant. I think it's still an important procedure to do when you're looking at poor performance horses, but I think you must take that in context with the clinical findings, a detailed clinical exam. It's important to still block out the rest of the leg and make sure that we haven't got anything going on in the distal limb before sort of jumping to conclusions that these changes are the primary and main cause of lameness. This was a nice case. It presented with a severe, had a fall, so acute onset, severe hind limb lameness, slightly ataxic behind as well. And we've got obvious disruption of this lumbosacral disc area. We've got disruption of the intertransverse joint compared to what it should normally be. And I think this case then sort of highlights that there's a lot we can't see ultrasonographically. So this horse was then put down and we did a post-mortem on it. And we can see that we've got, significant compression of that lumbosacral disc area. We've got compression of that spinal cord, which obviously accounts for the ataxia that we were then seeing clinically. We can see the sort of this is obviously chronic modelling of that intertransverse joint, so that's been going on a lot longer than the actual fall, but certainly I think this is significant. So I think, as Mariana said, there's a huge amount that we are missing, and hopefully, with the advancement of more better imaging equipment, so sort of more advanced CT and etc. in the future, then we will potentially then be able to see these changes in the live horse, or certainly determine their significance a bit more, with a bit more relevance. I've got a little bit more. Celia, do you want me to carry on? I can whiz through it. Okay, so just sacral fractures, again, not that common. They're mostly traumatic in origin, but again, we can get a good appreciation of these rectally. So clinical signs are very variable, pelvic pain, pelvic guarding, variable hind limb lameness, potentially ataxia as well. So this was a horse that actually presented with a rectal impaction, so it presented actually as a colic to the hospital as an emergency, and it had sustained a fall, and essentially what we can see radiographically is we've got a fracture of the first coccygeal vertebra here, complete displacement of the coxal vertebra compared to the sacrum. So here we've got there's huge disparity with respect to the bones here, so and then obviously a significant amount of associated soft tissue swelling as well. So we can get a very good appreciation of those rectally. This was another little one that presented again with a traumatic injury which went to bone scan, and again had fracture of C2 essentially here. So we can see that you're sort of almost coming out of the rectum at this point, but again we can see that change ultrasonographically as well as radiographically as well. So it's definitely worth making sure that you come out this far to look at the sacrum and and to look for coccygeal vertebrae. And then assessment of muscle, neurogenic atrophy. What we would expect to see is a much more echogenic muscle. Obviously, there's going to be less muscle compared to the normal side. Aortoiliac thrombosis, not particularly common. And so what we can then see is we've got a potential clot here sitting within this blood vessel here, and then when we add the Doppler into it, we can see that we've got partial blood flow around that clot, but obviously we've lost some, the width of that vessel, and we've lost some of that. So really just to summarise, I think I have a very sort of anatomical approach to when I'm scanning the pelvis. I like to do it very much in order so that I don't miss anything out. It is limited. We are looking at only the superficial structures, both transcutaneously as well as rectally, and it's important to combine that with other imaging modalities and definitely combine that with the clinical findings. And we really need, in particularly related to that sacroiliac lumbosacral area, we need to make sure that we put any significance of the findings and combine that with our diagnostic analgesia and our clinical examination. And as I alluded to again, the image quality is massively affected by breed. So big warm bloods, etc., are not, unfortunately, as rewarding as our thoroughbreds. Has anyone got any questions while we switch over to Sue?